gynecological emergencies. They have been calling it the wrong thing. Okay, this is probably when I first started teaching from this book, I never would have thought this statement is controversial, but in today's climate, saying that women are uniquely designed to conceive and give birth is controversial statement, but it is also a biologic fact. So we're going to teach from that perspective. There are numerous problems that women can have that men can't have, and problems that men can have that women can't have. Let's dig into some of those, and regardless of the social climate, I think you'll agree with me that some problems require an ovary or two and a uterus. Otherwise, those problems won't occur. So here we go. Questions about the anatomy, the external anatomy. Talk to your parents. Questions about how pregnancy happens. Talk to your parents or your spouse or your significant other. But hopefully you all came here knowing that. Ovaries are in the lower quadrants of the abdomen, usually one on the right and one on the left. Occasionally, a woman is born with only one ovary. I'm sure there have been cases of more than two. I just not familiar with that. There, at times, a woman may have ovarian cysts that result in one of the ovaries having to be removed and the other one left. It's possible that your patient could have had a hysterectomy and only had their uterus removed. If they've had a total hysterectomy, then the uterus and the ovaries have been removed. A few years ago, you could tell if a woman had had a hysterectomy. Usually you had to ask if they'd ever had a C-section delivery, but you could look at a scar on an abdomen and tell whether there had been either a C-section or a hysterectomy. But they do quite a few hysterectomies. They just call it a vaginal hysterectomy. They go through the vagina and they use a scope to do the hysterectomy without having to make a large abdominal incision. Recovery times are lower. The vaginal hysterectomy has its own set of complications, and major abdominal surgery has its own set of complications. I have a good friend who's an OB/GYN, and I was talking to him one time and asking him about vaginal hysterectomies, and he said, well, it's pretty much just like going in and overhauling an engine through the tailpipe, and then you're good to go. And all right, so that was all I found out. He really didn't tell me anything else. We laughed, and then our wives decided that it would be more appropriate dinner conversation than that, especially since we were in a restaurant. But I guess no conversation's off limits with me, because it just everything seems normal over food. You can ask our kids. Okay, the fallopian tubes connect the ovaries to the uterus. The uterus is a muscular organ. It is designed for an implanted fetus to grow, and then for when the pregnancy is full term, or if there's a short-circuited problem along the way, for that fetus to be born. And the vagina is the outermost portion of female reproductive system, and you have the external genitalia, and then the vagina on the inside. Then the cervix divides the vagina and the uterus. So the most superior part of the vagina is the cervix, or the most inferior portion of the uterus is the cervix. Same thing. And there's a picture for you. So you have to give a preview to these pictures. So you build up the anticipation, and then there it is. We'll spend more time on this, of course, when we do the obstetrics chapter. We'll go through childbirth and spend a lot more time on this. We'll spend a little time today on the endocrinology associated with at least maturation of a follicle within or maturation of an ovum within a follicle in the ovary, and then the rupture of that follicle, and then that's when the ovum is released and is available to be fertilized. Fertilization takes place within the fallopian tube, and we'll work through that later. A term to remember, which EMT students seem to frequently have a problem with, is menarche. Menarche is the onset of menstruation. So, and menarche takes place over the years, and they think possibly it's due to better diet. It also could be due to hormones in foods, with hormonal supplements in food that we eat. But menarche has taken place earlier and earlier over the years, and they tell me it's not uncommon to have a 9-year-old who experiences menarche. So that increases childbearing time. Earlier menarche does not necessarily mean that menopause, which would be the cessation of ovulation and menstruation, early menarche does not necessarily mean early menopause. So that increases childbearing years, dangers with very early menarche, combined, of course, with early the beginning of sexual activity at an early age. A 10 or 11-year-old's body has not grown and matured to the point that that body is really ready to have a baby. And most of those, they tell me, the delivery is by C-section, because the pelvis hasn't grown and developed to the point that a vaginal delivery is even possible. So I have no personal experience with that. That's just what I've been told. So that won't be on the exam, that an 11-year-old's body is not ready to deliver a baby. It does make sense to me. I borrowed this chapter from my medical emergencies class. It does, and you're not going to be tested over this, but there's other stuff that I'll hit in a minute that you will be tested over. But it gives you kind of a timeline representation of the menstrual cycle, and this top one, what takes place over a menstrual cycle. And the menstrual cycle starts on day 0 is the day that the menstrual period starts. And over that roughly 5-day menstrual period, the up here, the thickness of the endometrium, that's the uterine lining, it decreases, decreases, decreases. And then as hormone levels change, so what is the purpose? What is the purpose of all of this? The purpose of the next 23-ish days of the menstrual cycle is to increase the thickness of the endometrium so that it is ready for a fertilized ovum to implant and then grow to full term and end up with a baby. There are several hormones involved in this process. Hormone levels drop considerably during certain hormone levels drop during that 5-day menstrual period. That's part of the trigger of the whole thing. So you can see estrogen and progesterone drop considerably there, and then estrogen goes way up. Luteinizing hormone, follicle stimulating hormone, those are involved in maturing that ovum within the follicle, and then the big trigger of ovulation. Then you have your ovum or egg that's ready to be fertilized. Progesterone, which is testosterone in men, progesterone helps maintain that endometrium so that once, it will see more of this in a bullet point form in a few minutes, but once that, about 5 or 6 days after fertilization, when that fertilized ovum implants in the endometrium, that endometrium is at its thickest point. And then you can see as progesterone drops, that endometrium thins, and then boom, we go back to day 0 and start all over again. At ovulation, which occurs when that ovum, when these gonadotropic hormones have fully matured the ovum within the follicle, and all those follicles sit inside the ovaries. When these hormones have fully matured that follicle, there's usually an increase in body temperature. So you've had, because of hormone levels, normal 37 degrees Celsius is normal human body temperature. So graphically speaking, not graphic is in surprising detail, but following this graph, body temperature is low while estrogen and progesterone are low, and then as they start to come up, you have the big jump in body temperature. And prior to having home ovulation tests, body temperature was used a lot of times to help determine the day of ovulation for couples who were trying to have a baby. So that is kind of how that works. Ovulation, so we established what it is. Ovulation occurs after the ovum within the follicle sitting inside the ovary, and females of any mammal female is born with the total number of follicles that woman will have for her entire life. And normally only one follicle matures, or only one ovum matures within a follicle during a menstrual cycle. At ovulation, maybe light spotting. Spotting is just little drops of blood in the underwear. So light spotting. Some women, your book says maybe 20%, so that'd be like what, 1 out of 5 may have Mittelschmerz. That's a German word for middle pain, and we're about halfway through the total length of the menstrual cycle here, and at the time of ovulation, some women experience pain on one side of the pelvis, or cramping, or a little bit of pain. I can't tell you how much I have yet to ovulate, but that Mittelschmerz pain switches sides, because it can switch sides, because normally the ovaries alternate from month to month as to which one will have the follicle containing the ovum that matures and then ovulates. Other things that may be experienced at ovulation: breast tenderness, a little bit of abdominal bloating. Here's one that shouldn't be a surprise: increased sex drive. That's associated with the increasing progesterone level. And then heightened sense of smell, taste, or vision. Smell and taste I don't exactly get. The vision part, that makes sense, because everybody wants to have a pretty baby, so the woman must want to see a better looking man, and that I should stop there, right? Okay. As I said at the very beginning of this lecture, the fallopian tubes are where fertilization takes place. Why in the world does your book say the process of fertilization begins in the vagina? That is where copulation takes place, and ovulation combined with copulation leads to fertilization. So fertilization is the depositing of sperm from the male that goes deposited in the vagina, moves through the cervix into the uterus, up to the fallopian tubes, and the ovum should be somewhere within the fallopian tube and be fertilized there. And then it takes about 6 days, roughly a 6-day trip, for that, at this point, a zygote. For only 6 days, we have a zygote, and that zygote is that fertilized egg that immediately begins dividing just at an astronomical rate. That makes its way down into the uterus. That thickened endometrium, or lining of the uterus, is ready for that zygote to attach an implant. And once implantation takes place, that becomes a fetus, and that fetus develops from there. And this just is, this isn't in your book. This is a rendering of kind of what the trip's like for and the days involved. So you have ovulation, and that expels that oocyte, or ovum, as I've been calling it. Then you have fertilization here. You have cell division working its way down to day 6 or 7, 8 or 9. Your book says 6. This shows up to maybe day 8 or 9, implanting. And then something else that's interesting, that's also not in your book: so you won't be held to it, and I won't spend a lot of time there. Excuse me, I'm sorry. This shows the fetal development. I believe this is set out in weeks. So around that first week would be implantation. Week 3, the heart and central nervous system start to develop. Week 4, eyes, little buds for the limbs. And let's see. And this is representing major congenital anomalies. So as these structures develop, that's times that things can go haywire. That's what a congenital anomaly is. It's built in, and it happens partially because of genetics. It could also happen because of a teratogen. A teratogen, that's things like medications. If you were to get the full physician's desk reference, which is what we used to use to look up medications and learn about them back in the dark ages, when we had a big red book or blue book, and each year it alternated colors. You would see the teratogenic effects of these various medications in the physician's desk reference. And I think we're not going to spend a lot of time here. I could spend a whole day here, but the fetus has considerable protection early on from teratogens, but these dots represent what structures in fetal development are susceptible to teratogens along the way. All right, back to what your book says. That's just, it seems like fairly interesting stuff there, and a chance to lay somewhat of a foundation for your future EMS education. All right. If fertilization does not occur around day 14, the lining of the uterus starts to separate. No, I've said it wrong. If fertilization does not occur within roughly 14 days of ovulation, because we have a 28-day cycle. So the best chance of fertilization is going to be closer to ovulation, and as time passes, the percentage chance of fertilization decreases, and finally hormone levels drop to the point around day 28 that day 28 becomes day 0, and that's when the menstrual period begins. All right, so let's talk about pathophysiology regarding gynecologic emergencies. And there's a wide range of things, from STDs, now becoming known as STIs. I was told when I worked in public health that we were moving away from the word disease regarding STDs and going to infections because it was politically incorrect to use the word disease anymore, because that has a negative connotation and could make someone feel bad about themselves. But if we said STIs, then that doesn't sound quite as harsh. So that was more of what they thought was my education in public health. Okay, STDs can range from totally asymptomatic to life-threatening and eventually cause death. So let's talk about what, why, when, and all that cool stuff. Cause of death with an STD would be septic shock due to an infectious process or hemorrhagic shock from bleeding. So let's run through those. One of the life-threatening ones is toxic shock syndrome. Come to paramedic school and we'll spend a lot more time on that. I'm going to just bounce over it briefly with a couple of slides I borrowed from my advanced class. Septic shock would be secondary to pelvic inflammatory disease. We have too much information about, no, we don't. We have a lot of information about PID in this lecture. Uterine rupture, that would, of course, lead to hemorrhagic shock, and without surgical intervention, almost certain death. Ruptured ectopic pregnancy can lead to hemorrhagic shock and almost certain death. So as a clinician, if you neglect to consider a gynecologic cause of abdominal pain in a woman of childbearing years, you will miss the diagnosis 50% of the time, and that could be fatal to your patient. Toxic shock syndrome, that comes from just a proliferation of Staphylococcus aureus bacteria within the female reproductive tract. The bacteria aren't the cause of the problem here. It's the toxins that are excreted by the bacteria, and that leads to septic shock, massive vasodilation like we talked about before, and not enough fluid to fill up the pipes because the pipes got too big and our patient crashes and dies. Sudden onset of high fever. This used to be almost universally associated with tampons, leaving tampons in too long, and then having that overgrowth of staph, and then that leading to this condition. That some tampons now are treated with they have a kind of, started to say impregnated, that wouldn't be a good word here. They contain a something that will inhibit bacterial growth. They're not necessarily loaded with antibiotics, but I think they put something in there that inhibits bacterial growth, which is a good thing. Sudden onset of high fever, vomiting, diarrhea, muscle aches, hypotension, that could be all kinds of stuff so far. If you're also seeing a sunburn like a rash, and you're seeing these, I believe those are called purpura, these red blotches, it could be toxic shock. Our job in EMS isn't to diagnose. What our job would be to recognize that our patient is in septic shock and to manage that patient appropriately until that patient can receive definitive care, which would be IV antibiotics. So what are we going to do? We're going to manage the airway and breathing, and we're going to place the patient in shock position, along with managing the airway and breathing. That we're going to provide 100% O2. We're going to contact ALS and either have them come to our scene or rendezvous with us en route to the hospital. Why do we do that? ALS, they're not going to give them IV antibiotics that will address the underlying problem here. What they can do is infuse some IV fluid and administer vasoconstrictive medications to help increase perfusion by decreasing the size of the pipes, right? All right. And advanced airway management, if needed, they can intubate the patient. At the intermediate level, they can at least manage the air, do advanced airway management, and run in some IV fluid to expand the volume in the intravascular space and help raise the blood pressure until further management can be done at the hospital, such as vasoconstrictive medications. Okay, PID is an infectious process involving the upper organs of reproduction. So that would be the uterus, fallopian tubes, and ovaries. Almost exclusively in sexually active women. What normally happens, or well, what happens, not normally. What the pathophysiology of this would be an undiagnosed or either unrecognized, because some of these STDs can be asymptomatic. So unrecognized or at least undiagnosed and untreated sexually transmitted disease that causes an infection that proliferates through the upper reproductive tract and involves it causes things like scarring inside a fallopian tube. It can get up into the ovaries and cause sterility. It can kill all the rest of the follicles that are in there, and that patient won't ever be able to ovulate and become pregnant in the future. I've known of cases, this was more in my time of practicing law and dealing with criminal cases and children's protective services cases. I'm familiar with cases where you had a sexual molestation type situation and have a young girl who develops PID because her father transmits gonorrhea to her, and that gonorrhea ends up leads to sterility, and you have a little girl who will never be able to have kids because her dad needs to have his throat slit and thrown in the hog pen for the hogs to eat. But I got to be court appointed to defend folks like that. It's hard to defend somebody you want to kill, but I had to. All right. PID is a clinical diagnosis. There's no specific or no lab tests that we're not going to run lab tests anyway, but clinical diagnosis, what is that? Normally just across the board in medicine, that's when signs and symptoms are used to determine what's wrong with the patient. Although we don't diagnose patients in EMS, clinical diagnosis is what we do, right? Other than getting a BGL, it's all, quote, clinical diagnosis. Again, we don't diagnose. But patient may be asymptomatic, never realize that they had an STD that eventually led to PID. Pain. So what signs and symptoms do we see? Pain in lower abdominal quadrants. It doesn't have to be both. Just depends on the location of the infection. Fever and vaginal discharge. Normally it's a foul smelling vaginal discharge. Painful intercourse, bleeding after intercourse, dysuria, and bleeding between periods. Wow, that sounds like we're going to get to ask gentlemen and ladies. I always, for years, I've said, gentlemen, we're going to have to ask some uncomfortable questions. And then one of my lady EMT students told me, no, we're going to all have to ask some uncomfortable questions. So it'll never, well, if you run enough of these calls, they become routine questions. Things that I learned over time. Don't necessarily look your patient in the eye while you're asking the questions. That makes it a little easier early on. After you've been at this a while, you'll be able to walk up to anybody on the street and ask them these questions. I don't recommend it. You might be beaten in the head with a purse, but okay. So let's talk about a few specific sexually transmitted diseases, and then we will move away from this, because that's what we all want to do, is always move away from STDs. They're a plug for my former career in public health. Chlamydia is the most common STD. Quite frequently, it's asymptomatic or has such mild symptoms that the woman doesn't even notice that there's anything going on. Really the same thing with a man, but we're not talking about men parts today. Can spread to the rectum, and it can also proliferate from the lower reproductive tract into the upper reproductive organs in women and cause PID. Bacterial vaginosis is the most common vaginal infection to affect women. Problems with bacterial vaginosis, and we just talked about, or I just mentioned, toxic shock syndrome. Where do the bacteria come from that grow, say, on that tampon that leads to that proliferation of that Staph aureus bacteria, and then those toxins cause septic shock? That's the word I'm looking for. Why didn't you guys tell me? That eventually can cause septic shock and kill our patient. Those bacteria can frequently start with bacterial vaginosis and then just proliferate from there. Let's say that doesn't happen, because that's a very rare condition. But so if that doesn't happen, what can happen with, what can the problems be with bacterial vaginosis? Premature birth, low birth weight, and then possibly PID. Gonorrhea. Gonorrhea is a bacterial sexually transmitted disease. Fortunately for much of the world, gonorrhea responds well to several different antibiotics. Like most bacteria, it grows really well in warm, moist places, and that happens to be the exact nature of the female and male reproductive tract. Again, we're not talking about men today, so even though most things are our fault, you can trace it back to us. Okay, gonorrhea affects men and women fairly equally, not exactly equally. Severe gonorrheal infections present with signs and symptoms such as lower abdominal cramping, abdominal pain, nausea, vomiting. Man, that just sounds like that could be a GI virus. That could be all kinds of stuff, right? Now let's throw in there bleeding between periods and vaginal discharge, which is malodorous. again, we're going to have to ask some questions, guys. All right. And ladies, just, and I don't know whether it's easier for a woman to ask those questions of a female patient, or anyway, we both have to do it. So we'll keep on asking questions, and we need to ask them in the way that is, I'm not worried about whether you or I are all that uncomfortable. I'm worried about trying to get the information we need without making our patients too uncomfortable. All right. Syphilis, it is also an STD. It's caused by a bacteria. I'll show you what it looks like in just a second. This one has stages. So it 3 distinct stages. We'll talk about that in a minute. This syphilis can become a chronic condition that has very distinct systemic effects, and we'll talk about those in a minute. There is electron microscope picture of what this thing looks like. That is called a spirochete, I believe. Sexual transmission is one mode of transmission. Also vertical transmission, mother to child transmission, directly to the, so let's take HIV. HIV can be passed from mother to child, but that's normally during the birth process. Syphilis can be passed from the mother to the embryo, fetus, or to the baby during childbirth. It's most contagious to sex partners during the primary and secondary stages. Once it's moved into tertiary syphilis with the patient, stage 3, it is no longer sexually transmissible, but you can have a mixture of stages 1, 2, and 3. So they're not separate and distinct. You can have multiple stages going on at the same time. Tons of syphilis in the 1940s. After penicillin was developed in the 40s, and public health started really aggressively providing information on and treating syphilis, there was a major decline in syphilis cases. And then in the mid to late 80s, there's a great big jump in primary and secondary syphilis. This is from a presentation that I did when I worked in public health. It can also be passed men to men. So another thing I learned in public health, this MSM, men who have sex with men, that is an at-risk population. Syphilis can be passed orally, anally, vaginally. It is, as can gonorrhea, actually. Okay, that graph means nothing. We don't need to worry with that right there. Primary syphilis, a canker appears. That is at the site that syphilis is spread into the patient. And I have a couple of pictures of those lesions in a minute. That lesion will, you have multiple lesions can occur. That lesion heals, the primary canker heals, and then it moves into having, there are secondary cankers. Lymphadenopathy, that's swelling lymph nodes. That goes with infections in general. Okay, there is one of the cankers. That is a tongue, and that is a canker on a tongue. You get cankers on the in the mouth, cankers on the genitalia, and they're wicked looking. And I hated being around STD clinic, honestly. They called me and another middle-aged man for security. When somebody was getting rowdy and getting out of control, we'd have to go stand in the exam room with the STD nurses while they did pelvic exams. And oh man. Or when there was a man who was either being a little bit too flirty or seemed like he was about to get violent. Okay, let's see. And then you have a rash that goes with syphilis. I'm not good with rashes. Unique thing about these rashes is that they're not all at the site of the infection. They pop up on the palms of the hands and the plantar aspect of the feet. These are secondary syphilis lesions, nickel and dime lesions on the face. Latent syphilis, moving into that tertiary phase. And we don't need to worry about early and latent. The big thing about tertiary syphilis is it attacks the central nervous system, and it is often asymptomatic early. It results from untreated syphilis, and it can take years. Al Capone, if you're familiar with the old Chicago gangster Al Capone, Al Capone pretty much became an insane man in his latter years because of neurosyphilis. He had tertiary syphilis that attacked his brain, and he just was a crazy man there toward the end of his life. He wasn't exactly sane early on, but okay. Those little spirochetes that I showed you the picture of before, this is what they look like in neurologic tissue. Good news is that antibiotics, that syphilis responds well to antibiotics. Something interesting, cardiovascular tissue can be attacked by syphilis. Have this, and this is, it's hard to see, but that is syphilis within a heart anyway. This is a little one with mucus patches that go with syphilis. Cupping of the teeth in syphilis that was passed vertically or from mother to child. You can see Hutchinson's teeth, and that's that kind of cupping appearance of teeth. And then there is a perforated soft palate from it. Responds well to penicillin, also doxycycline and tetracycline. Okay. Vaginal bleeding. Do vaginal bleeding, and then we'll take a break. Possible causes of vaginal bleeding. Just abnormal menstruation, heavier menstruation than normal. Could be from a condition known as endometriosis. Endometriosis, one of the things that goes along with endometriosis is very inflamed, like hyperdevelopment of the lining of the uterus. So that extra thick uterine lining results in more bleeding during the menstrual period phase of the menstrual cycle. Also can cause, endometriosis can cause severe abdominal pain. Their cells can develop within the abdominal cavity that are very similar to they are similar to the endometrium. So as those hormone levels come up, that causes a thickening of the lining of the uterus. It also causes inflammation of those endometrial-like cells throughout the abdomen, and that can cause some horrendous abdominal pain. So that could be the source of abdominal pain in a female patient of childbearing years. Vaginal trauma can cause vaginal bleeding. Ectopic pregnancy, we'll have a whole section on that in the obstetrics chapter. Spontaneous abortion, what is that? That is a miscarriage, is what normal people call it. In our world, it's a spontaneous abortion. In our world, you have spontaneous abortion, which is a miscarriage. Then you have a therapeutic abortion, which would be in the news when you hear all the arguments about abortion, and I won't go into any of those, but when you hear about the abortion to save the life of a mother, that's a therapeutic abortion. And then an elective abortion is the Roe versus Wade, go down to the clinic and into pregnancy type abortion. All right. Cervical polyps can cause vaginal bleeding. Cancer can cause vaginal bleeding. Does it look to you? It looks to me like that it'd be really difficult for us to determine the cause of vaginal bleeding, except for maybe vaginal trauma, and probably due to a sexual assault. And it depends on the amount of the vaginal bleeding. Most of the time, we're not looking under the hood to see where the blood's coming from. So there's very few times is there cause for an EMT, an advanced EMT, or a paramedic to visualize a woman's vagina for anything other than childbirth or severe bleeding. Okay, let's take 5 minutes there, and then we'll blast through the rest of this. We're about halfway done, or more than halfway done with this chapter. Questions so far? Scene size up. So, gynecologic emergencies, do they follow the medical assessment algorithm or the trauma assessment algorithm? Or could it be both? Yes, it could be both. Could be either and or. All right. That sounds like a lawyer talking again, doesn't it? Okay, scene safety. Some gynecologic emergencies can involve large amounts of blood. Remember universal precautions, how I told you that works. If it's wet and sticky and ain't yours, don't touch it without protecting yourself with gloves, gown, mask, face shield, whatever it takes to protect yourself. Your safety is always number one, then your partner, then your patient. Okay. If you suspect that there has been a sexual assault, your book says involve the police. I'm going to tell you that that's not optional. That is one of those mandatory report situations. What if you suspect that a young girl has been victim of a sexual assault? Do you confront her family, confront her father, her brother, whoever you think the culprit might be? No, that is not your job. And that goes back to scene safety. That would be potentially a very unsafe situation for you. And it's not your role. Your role is to provide patient care. And quite often this patient care is just reassurance and a smooth ride to the hospital. But if you suspect that there has been a sexual assault, then you need to request law enforcement. Or if your conversation with your patient between the time you first make patient contact and you get to the hospital, maybe you're on the road, maybe you're going down the road getting a sample history and going through your OPQRST, and it in that patient assessment, you believe that your patient has been sexually assaulted. You need to, in private and outside of the hearing of the patient, I think, whoever the nurse or doctor that you're giving your patient, whoever you're reporting off to, I can't find words today. Maybe I had a stroke. When was the last time I was known to be normal? Nobody can answer that. Probably never. Okay. That's a joke that you understand now that you might not have 2 weeks ago. All right. In private, just convey your suspicion that there's been a sexual assault to the person you report off to. It may even be writing on a paper towel. Grab a paper towel, because there's so much going on. There's really no way to move outside the exam room, the treatment room, wherever you are, to convey that information. You could just write it on a paper towel and then make sure you dispose of that paper towel properly. Don't put any name on it or anything. And then you have an obligation to contact the police and report that. That is a legal duty. It's not a recommendation. Investigate the chief complaint. Questions can be very personal. Be professional about it. Use clinical terminology such as vagina or rectum, not slang terms, unless they flat just don't understand what you're talking about. And I have been there before. Have you had any vaginal bleeding? Well, I don't know what you're talking about. Hopefully by now people, a lot of information available out there. Hopefully almost everybody is familiar with clinical terminology for body parts, but sometimes people just don't get it, and you have to convey the information the best way you can. We'll talk about sexual assaults at the very end of the lecture. Sexual assault is about power and control. More than it's about sexual gratification. I have responded to sexual assaults on 2-year-olds. I've responded to sexual assaults on 20-year-olds, and I've responded to sexual assault of a 90-year-old. So just because your patient is elderly or really young does not rule out the possibility of a sexual assault. For the record, those things make me want to hurt someone. Okay, with abdominal pain, this should look familiar, right? We're kind of talking OPQRST here, aren't we? That's exactly what you're doing. Man, provoking and relieving factors. What does that sound like? That's the P, provokes or palliates, right? And then associated symptoms with abdominal pain in a woman of childbearing age. You're going to have to ask, have you had any vaginal discharge with it? If so, if they say yes, then you're going to have to ask the follow-up question. Does that discharge have a foul odor? If they tell you, have you had any vaginal discharge, they say yes. Also ask, is that abnormal for you? Yes. And then does it have a specific odor? And right on down the line. Color, what color is it? Onset, duration, quality, or quantity. Number of sanitary pads soaked is one way of estimating blood loss. There's like the 5, 10, 15 rule. Roughly a normal tampon holds 5 cc's, and then a normal size pad holds 10 cc's, and a maxi pad holds 15, roughly. That varies because they're always changing those things up, so they can charge more for them, I'm sure. Have no personal experience, so I don't know, other than the pads that we carry on the ambulance, those Surgi pads that look like a sanitary pad, and that's what we use on vaginal, used to control vaginal bleeding. Okay, any associated signs and symptoms? Syncope would be a big one. What would cause a patient with vaginal bleeding to have a syncopal episode? They're not perfusing their brain well. Why are they not perfusing their brain well? One big reason could be that they're starting to move toward hemorrhagic shock, and that can cause postural syncope. They go from sitting to standing, and the vasoconstriction doesn't keep up with it, and they have a syncopal episode. I would recommend getting postural vital signs on any patient with vaginal bleeding. What is that? We're going to get a lying supine blood pressure and heart rate, and then we're going to sit the patient up and get a high Fowler's blood pressure and heart rate. What would tell you that your patient is starting to become hypovolemic? If their heart rate goes up when you raise the head of the bed straight up and down, or the head of your cot straight up and down, and possibly even the blood pressure drops a little bit, that would be, call that a positive tilt test. This is the tilt test, supine to high Fowler's, and then standing. We usually don't have them stand in EMS, but if you hear somebody talk about a tilt test, that's what they mean. We're going to get vital signs when our patient's supine, and we're going to sit them straight up and down and get vital signs and look for any change that would indicate possible hypovolemic shock. And really, with any patient with abdominal pain, that wouldn't be a bad idea if they will tolerate lying flat. Patient with appendicitis isn't going to, but if you suspect internal bleeding, and you're not worried about spinal precautions, you could always do that tilt test. There's nothing wrong with that. If you have a critical patient, don't jack around and take time to do that. We don't have time to stay on the scene forever. We need to be worried about the platinum 10. So whether that you have a critical patient from vaginal bleeding, or critical patient from blunt force trauma to the right upper quadrant, we don't have time to play around on scene. Other things we need to ask in our sample history: are you sexually active? Is there a chance that you could be pregnant? Do you use do you take birth control pills? That would be the M, right? Any other birth control devices? And then we need to ask, what was the date of your last known menstrual period? If they give us a date within and a few people just flat don't know, but most will have a rough idea. If not, ask if it's been more than a month. Has it been more than 2 months? If it's Easter and they don't know, was it around Valentine's Day? Was it back around Christmas? Well, I don't know. I just don't keep up with it. And all you can do is ask the question. You can't provide the answer also. And then, have you been diagnosed with any sexually transmitted diseases, or is there a chance that you might have one now? Okay. And then I've already talked about blood pressure and pulse, orthostatic vital signs. That goes along with that tilt test that I was talking about. And then skin color. All of those would help you with determining if your patient has signs and symptoms of hemorrhagic shock. Could your patient have pelvic inflammatory disease and also have internal bleeding that's causing hemorrhagic shock? So maybe they have a mixture of septic shock and hemorrhagic shock. Absolutely, they could. What does that mean? They're not going to be able to compensate as well in the hemorrhagic shock, and they're going to move to decompensated shock than irreversible shock much quicker than they would if they didn't have that infectious process going on. Any genitourinary bleeding visible, a lot of times for us, that's just going to be, do we see blood soaking through the patient's panties, or do they tell us that they have, that they're spotting or they're having vaginal bleeding? It's absolutely necessary that you ask these patients if they've had any vaginal bleeding, how much, all of those things, and then note their mental status. We're only going to examine the genitalia when absolutely necessary. In the non-pre-hospital clinical world, it's almost always possible to have a female clinician in the room when a male is examining a female's genitalia. You may be, gentlemen, you may be on a truck and it's you and another man, and there are no women around to be in the room or in the back of that box with you when you're doing that exam. So that, we're talking uncontrolled bleeding, and it's absolutely necessary to examine the genitalia. If law enforcement is there, if fire department is there, then I think it would be important always to have somebody who's not a crew member on your ambulance to be present, maybe not down at the foot of the cot, visualizing very private area along with you, but present in the box so that they can see what you're doing, so they can, that's another witness. If you were hauled to court or somebody tried to press charges against you for something, there will at least be a disinterested witness who could say, no, all he did was pull the panties down and put Surgipad on there to catch the blood, and then change the Surgipads as they got soaked. So it's rare that you're going to do this, but try to think ahead and have a disinterested third party. Probably not a family member. They're not disinterested third parties, and most women don't want a family member present in the room when this type of examination is taking place. Okay, visualize the bleeding. Ask about the quality and the quantity. Is it a steady flow? Is it a heavy flow? Is it an intermittent flow? It could be that I ran a call where college-age young lady was sexually assaulted with a large knife, and it was major bleeding, and we don't pack anything inside the vagina. We don't insert anything in the vagina to try to deal with the bleeding. So all I could do was try to treat for shock and change pad after pad after pad that became blood soaked. That was it. If you are visualizing the vagina, you're not going to visualize the vagina for just for any discharge other than bleeding and major bleeding. So we're not going to be looking to see if it's a yellowish discharge or a clear discharge or a green discharge. That is just outside of what you need to be doing. And then we need to ask questions about lightheadedness, possible syncopal episodes. If they're afebrile, meaning they don't have a fever, we need to ask, have you had a fever and have you taken anything for that fever, such as Tylenol, ibuprofen, Aleve, any of those NSAIDs that would mask that fever that we might otherwise see in, say, our patient with PID. We need to ask about if they've taken anything like that that would mask that fever. Do you have any nausea, any vomiting? Have you had, and when you're getting that history of present illness, you need to also ask about any previous gynecologic emergencies. Anything like this ever happened to you before? And then reassessment, same as always. And there's that 5, 10, 15 rule. I didn't have to remember it. It was right there. Okay. And I threw that 5, 10, 15 rule in there because your book talks about the number of pads and estimating blood loss, but if you don't have anything to work from, what in the heck does it mean? So if your patient has, and these are rules of thumb, these aren't absolutes, but if that maxi pad held, let's round it up, let's say it's 20 cc's, and they have completely saturated 10 of them, then if it's 20 cc's, that's 2 liters of blood, right? So that is significant blood loss. That's probably close to half of the total circulating blood volume in most women. So that's why I put this 5, 10, 15 in here. So this is something for you to work off of in your head to estimate blood loss. This isn't a hard and fast rule like you're going to put in your patient care report. What would you put in your PCR? Patient stated that she was using maxi pads and that she completely saturated 10 of them. In fact, if those 10 are in a trash can in the bathroom, then I would say tie up that trash bag and take that sucker with you. And then at the hospital, if they want to look, they can look and see how saturated those pads, how saturated those pads were. So ask how this compares to their normal menstrual flow. And you may get all kinds of answers. You may get very defensive answers. You may get even hostile answers, but you need to ask questions. I already talked about endometriosis. Trauma to the external genitalia is very painful. From running these calls, I can tell you from my patients that these are very painful injuries. One that's not uncommon, little girls riding boys' bicycles with that center post or that top rail, and fall and land on that thing, or slip and fall in a bicycle seat. and get a labial tear that can cause significant bleeding. You don't need to look, you just need to put a pad there to catch the blood. Okay, put and moisten those so they don't stick to. Why would we moisten one of these dressings? We're going to put water on it, sterile water, and have a moist sterile compress, because at the hospital, when they start to remove that, if it's moist, it will come away smoothly and not tear away any clotting that has taken place. So that's why we're going to use a wet dressing. Really the same thing with any dressing that we're putting on an injury. Okay. And again, I said don't place anything in the vagina or pack the vagina with anything. PID we've already talked about. So how do we treat PID? Because your book says pre-hospital treatment is limited. Smooth ride. PID can cause peritonitis. Peritonitis, remember, your patient can have rebound tenderness with peritonitis. Peritonitis causes a generalized, non-localized pain, and every little bump is going to cause pain in that patient. So if you're in the back of the truck and your partner is not giving you a smooth enough ride, then you better be reminding them, because that's part of good patient care. Lean up there and say, slow down, give me a smooth ride, whatever you need to say to convey the information. I have a younger, a little more assertive me has been known to throw things from the back of the truck up to my partner to get them to listen to me to slow down. I've heard of somebody who resembled me throwing a liter bag of IV fluid and hitting someone who was driving because they wouldn't slow down and give me a smooth enough. Give that guy a smooth enough ride. I don't recommend that. Could hit that driver and cause a wreck, but I was pretty pissed because I'd ask over and over and over. Most sexual assaults we're not called to. Most sexual assaults are transported to the hospital by means other than EMS. You will run sexual assault calls in all likelihood. Tough situations. At times, you will be the first person that victim encounters after they have been sexually assaulted. Professionalism, tact, kindness, those are important with any patient, but just kindness and supportive care may be all you have to offer, plus helping to preserve evidence. That is another important part of what we do. You may encounter a victim of sexual assault who has been, these are date rape drugs, Rohypnol and others. They used to be called Mickeys, or a Mickey Finn. I don't know where that name came from. Doesn't matter. Ain't in your book. I ain't gonna ask you about it. But that those date rape drugs can be used. So Rohypnol, you could have a patient who has signs and symptoms of a benzodiazepine overdose or an opiate overdose, or at least benzo or opiate intoxication, along with the sexual assault. So you may have, back to that toxicology chapter that I did such a poor job of covering, that you could have a patient who has clinical signs and symptoms associated with that, plus the sexual assault. If possible, give your patient the option of being assessed and treated by a female EMT. it's more likely now in EMS that there's going to be the option of having a female crew member to assess and treat that patient. Back in the years I worked in the field, at the most 38 field employees that we had, we never had more than 3 women EMTs or paramedics at any one time. So that's different now. We have roughly half and half. But if your patient is non-critical and they are not comfortable with a male crew member treating them, you could always call dispatch with your cell phone and say, hey, can you dispatch a unit to my location with a female crew member? That could also apply in a non-critical situation if you have a patient whose religious beliefs or their cultural or ethnic customs prohibit them from being examined by a male clinician. If they're critical, involve law enforcement and don't delay. But if they're non-critical in that ethnic or cultural situation, you could do the same as I'm talking about here. Have dispatch a crew with a female crew member to your location. Okay, what should your focus be in a patient who is a possible victim of sexual assault? Medical treatment, absolutely. And then psychological care, that's reassurance and providing comfort. And then preserving evidence. Don't throw away clothes, don't cut through clothing, don't throw it down on the floor and stomp on it, don't put it in plastic bags. Evidence goes in paper bags, particularly this kind of evidence, because there's no interaction with the plastics, and brown paper, just a regular old brown paper sack, is more likely to preserve evidence, not destroy DNA. DNA could be the only thing that helps locate the perpetrator with a sexual assault. And then we need to get a good patient history. You don't have to talk to your patient, but I have a loud voice and I have a fairly deep voice, so decreasing the volume and kind of approaching it like more of a quiet conversation, much more appropriate. In fact, I think pretty much mandatory in my mind. Physical injuries, life-threatening injuries. There are lots of very violent sexual assaults, and your patient could have blunt force abdominal trauma, could have head trauma, need to do a good head-to-toe physical examination to look for life threats and be ready to respond appropriately to those. If there are life threats, we have to treat them. That doesn't mean that all of these other things I've been talking about with the sexual assault are not important anymore, but they take a back seat to us treating life-threatening injuries. You can preserve evidence and still manage life threats. Psychological care, non-judgmental. If you run on a young woman who was sexually assaulted in a car in the parking lot of a bar after she became intoxicated and then went out to the car to talk to a guy she just met, or maybe somebody she has known for a long time, but they go out to a car and she's sexually assaulted, never approach that as if she she asked for it or she got what was coming to her or any of those things. Nobody ever deserves to be sexually assaulted. Uh, at times, people exercise some poor judgment. I do also. Maybe my poor judgment that I've exercised in the past or will in the future, it may be different than this, but it's just in a momentary lapse of judgment or trusting the wrong person can be lethal or at least cause some major issues for our patients. And I've told you since the start of the class that the best thing we can do to keep ourselves and our patients safe is to get them in our environment, which is the back of our truck with the doors locked. That gets our patient out of the view of other people, and that is the best thing you can do for you and for your patient. Don't cut through any clothing. Don't throw away anything from the scene. Blood-soaked clothing, blood-stained clothing goes in separate paper bags. So what do I mean by that? Say the panties go in one bag, bra goes in another, pants go in another, shirt goes in another. So the problem is you may not have these paper bags on your ambulance. Law enforcement will have these paper bags. Don't try not to do anything that's going to interfere with them processing the crime scene. Only touch what you have to, which is mostly going to be your patient and then your equipment, maybe a door handle to get in and out. Leave the door open so you don't have to keep touching the doorknob or button to go in and out of a room. Don't grab every lamp in the room to touch it or every flower vase. You're just interfering with evidence that could be used to identify the person who perpetrated the violent crime. Need to be firm about this without being mean, but you need to discourage your patients from urinating, changing clothes, having a bowel movement, rinsing out their mouths. And that's difficult. And you need to explain why, because what are they going to want to do? They shouldn't, because it's not their fault, but the victim of a sexual assault feels like they need to clean up. They feel dirty. They feel like they maybe have the smell of the cologne of that person on them, or I just feel like I smell like him. So need to explain to them that we're here to take care of you, but we also need to help the police investigate this thing and try to catch the person who did this to you. So I really need to ask you not to, because they're going to want to go pee. They're going to want to go, I feel like I got to go poop. Let me just get some mouthwash, whatever, and explain to them and reassure them that they'll get to do that as soon as possible. But in the meantime, we need to help them preserve evidence, and then it may be appropriate to explain to them that, and I wouldn't go into all the, you're going to be photographed and you're going to have all this, and they're going to take vaginal swabs and they're going to do all this stuff, and I want you to be prepared for it. Don't do that to your patient. That is not your role. If they want to go to the bathroom, change clothes, have a bowel movement, use some mouthwash, just tell them that they're going to be collecting other evidence at the hospital, and it's really best if you wait till they tell you it's okay, because they have specially trained nurses. They have specially trained sexual assault nurses at the hospital to help examine the patient, to help reassure the patient. They have a team, and there is a certification for nurses. They can be certified as a specialist in sexual assault. So, and that also includes testifying in court, and they're dang good at it. So, there are professionals at the hospital to help them, and be sure to try to convey that without getting into graphic details. It's not your place to do that. You're just going to create more apprehension in your patient, and that's just not something we need to do. Treatment principles are there in that graph if you prefer that. And that is the end of that chapter. Questions? Trauma overview. From the beginning of the course, when we first exposed you to our patient assessment algorithm, and we first started talking about the primary survey, we've talked about MOI and NOI, mechanism of injury and nature of illness. We've just spent about 3 weeks going through part of the things that make up nature of illness. Most of the things, at least EMT wise, from your book, we've covered in nature of illness. So now we move on to mechanism of injury. Trauma, in some ways, isn't as complicated as the medical chapters that we've just gone through, other than the fact that some trauma isn't obvious, and you have to do a good patient assessment in order to find it. Before we start breaking down trauma into head trauma, head and neck trauma, or head, neck, and spine trauma, chest trauma, abdominal trauma, musculoskeletal trauma, all of those things, we're first going to talk about several things with mechanism of injury that are crucial in your understanding of all those other trauma to all those other body systems. If you don't understand mechanism of injury, you may not be able to determine whether something is emergent or non-emergent. So let's hit a little bit of this. I'm not a physics professor. I guarantee you most of you have had classroom exposure to physics much more recently than I have. So we're not going to do a bunch of calculations or anything like that. Whew, thank God for me. But we are going to talk about a few concepts of energy, and then how those apply to the body and apply to trauma on the body, which would be the pathophysiology of trauma, how trauma affects the human body. So potential energy is stored injury. Energy, I can't talk. Energy can cause injury, but injury is not necessarily energy. All right. Stored energy. Think about a construction site, and there's scaffolding set up because they're bricking the outside of a building. They're doing a brick veneer job, and 2 stories up on this scaffolding, there sits a brick. Is that brick hurting anything? Will that brick hurt you? Just in its present location on a scaffolding board, 2 stories up, that brick only has potential energy. There's potential for that brick to cause injury upon whoever might happen by. It's not until that brick is placed in motion that it can fly through the air and hurt someone. So that brick falling through the air that came off of that scaffolding board 2 stories up, it now has kinetic energy as it falls, and force acting over a distance is the energy of work. So the work of that kinetic energy of that brick falling through the air when it strikes you, that is force acting over a distance. So let's apply that a little better work. Forces that bend, pull, or compress tissue beyond their inherent limits results in injury. All right. You didn't have to come to EMT class to know that, right? A brick that falls 3 stories and hits you in the head could hurt you. You knew that before you got out of grade school, right? That's why you didn't walk under scaffolding when you were in 3rd grade, because you knew those bricks had potential energy, and if somebody knocked one of them off, then that kinetic energy in the end could result in injury. So, and also in the 3rd grade, you knew that kinetic energy equals 1/2 the mass times the velocity squared. Of course, we all knew that in the 3rd grade. I don't know that I knew what 1/2 or squared was in the 3rd grade. It was not my job. My job was to throw a baseball, football, basketball, ride my bike. And that was it. And have an occasional fist fight on the playground. So that's what we did for fun. So let's move from bricks to vehicles now. I want you to picture a smart car, the little 2-seat car that looks like it should be at the circus. I apologize if any of you drive one and I'm offending you, or if your dream for going into EMS is that you'll be able to afford a smart car, I apologize. But let's picture that little smart car that maybe it might not even weigh 2,000 pounds. And now let's picture just a normal old 1/2-ton pickup truck. Pretty common in our part of the world, right? Much more common than a smart car. So the energy when you move from a 2,000-pound smart car to a 4,000-pound 1/2-ton pickup truck, and I think they actually weigh a little more than that, but we're just assuming lots of things here. That the energy that is produced by that pickup truck is double the energy produced by that little smart car. That little smart car going 20 miles an hour produces a set amount of energy, and it would be a pickup truck going 20 miles an hour, and if it weighed twice what the smart car did, there would be double the amount of damage from the energy in those 2 vehicles. This is a lot harder without drawing it on the board. I hope you're picturing things well, because I don't think I'm explaining it really well. But that little smart car, if you double the speed from 20 to 40 and run into a brick wall. Oh yeah, these things are running into brick walls. That's what I miss, because I always draw a brick wall. That little smart car at 20 miles an hour has a fixed amount of energy when it hits a concrete wall. And that pickup truck that weighs twice as much would have twice the amount of energy when it impacted that wall. But if you double the speed of the smart car from 20 to 40, it quadruples the energy when that smart car hits that brick wall. So speed, you've heard maybe you haven't. There used to be an old commercial that showed all these mangled up cars and supposedly dead people, and it said speed kills. But it does, because that increase in velocity, that is an exponential increase in kinetic energy, where mass and weight aren't the same thing, but they're close enough for what we're doing now. So that mass, it doesn't increase as quickly. And kinetic energy is half the mass times velocity squared. All right. Enough of that. Hopefully they don't throw that at you on the National Registry. Okay. Potential energy, product of mass, the force of gravity, and height. So think about things falling out of the sky. Wheel falling off of Southwest Airlines 737 from 40,000 feet, and it's going to reach terminal velocity after a while, so that it doesn't, the speed doesn't increase anymore. But that height causes that wheel to have much more kinetic energy upon impacting you than that same wheel falling from 10 feet would. I think you get the picture. I think I probably get too hung up on that stuff, but it's important that you understand it. MOIs produce many types of injuries, so we need to talk about MOIs and get an idea of what they cause. Non-significant injuries, maybe an injury, it could be an injury to an isolated body part. You could have a significant injury to an isolated body part that becomes very significant. But normally we just associate isolated body part injury with non-significant. So that just means, by its very nature, injury to an isolated body part doesn't have to be significant. It can quite often be non-significant, kind of like my lecture, non-significant. And then a fall without loss of consciousness. Significant injuries, anything that's multi-systems trauma. What is that? Involves more than one body system. Have chest and head injuries. So that's multi-systems trauma. And that is get on your horse and go, no, let's put them in the back of an ambulance actually, and apply either gasoline or diesel therapy depending on what kind of vehicle you're in. That's the skinny pedal on the right to get you to the hospital, because trauma is a surgical disease, not one that can be managed medically. We can't take a bronchodilator like you learned to administer with a nebulizer in lab yesterday. We can't fix trauma with something like that. Trauma requires surgical intervention. We can control external bleeding. We can manage the airway. We can do all those kinds of things, but we can't fix it. Falls from heights. We'll talk about how high it has to be for it to be a significant height that would cause significant injuries. And vehicle crashes, blunt force trauma, that doesn't break the surface of the skin. It doesn't penetrate a body cavity. It is force applied over a wider area without penetrating soft tissue. Penetrating trauma should be fairly obvious to you by now. Trauma that pierces or penetrates the surface of the body. Think about blunt trauma, a patient being whacked in the abdomen with the baseball bat versus being stabbed with a Bowie knife. That's the difference in blunt force trauma and penetrating trauma. Patients can have both. MVCs, falls, being beaten with a 2x4 or baseball bat. Those are fairly common MOIs. And again, MOIs, mechanism of injury. What do we have to look for as a sign that our patient has experienced blunt force trauma? Skin discoloration, or palpation elicits pain, or they just tell us that they hurt. So when did your stomach ache start? It's right after I fell off the roof and landed on that big planter over there and it hit me right across my gut. Uh-oh. Okay. So blunt force trauma, we're going to have a high index of suspicion of hidden injuries, and we're going to have to fully assess our patient to determine whether our index of suspicion ends up panning out so that we find signs and symptoms of internal bleeding. Let's talk about collisions. Collisions seem to be important in this whole thing. There are 3. That doesn't mean 3 separate car wrecks. Collision number 1, exterior of the vehicle strikes something. All right. So we're back to force or kinetic energy, and it's a function of mass and acceleration or deceleration. Collision number 2, stuff within the vehicle moves toward the point of impact. That includes the folks in the vehicle, their stuff. They're not. That might hurt their feelings if we call them stuff, but anything contained within that vehicle, when that front of that vehicle impacts that concrete wall, is going to move toward that point of impact. What actually happens is the vehicle begins to stop from collision number 1, and nothing has acted upon stuff number 2 or nothing is acted upon the stuff within the vehicle, so it continues to move forward until acted upon by an outside force, right? Object in motion tends to stay in motion unless acted upon by an outside force. That outside force could be friction. That outside force could be let's say you're going to go out in the country and shoot rabbits, and you're going to take 2 pistols. You're going to take your Glock. You're going to take your grandpa's .357 Magnum revolver, and you're going to take your AR-15 with you, and you're going to go out to try to shoot some rabbits, and you put those weapons in the back seat of your vehicle, and then you are involved in a car collision, and those 2 handguns and that AR-15 rifle in your back seat become flying objects that might impact you in the head and cause some significant injury. So I don't know, you're texting your buddy about where to meet you when you're going shooting, and you drive straight into that concrete wall. Collision number 1, hit the concrete wall. Collision number 2 is you and the stuff within the vehicle moving toward that point of impact. Collision number 3 is stuff within the patient's body striking the inside of the patient's body. We'll work on that a little more in a second. Solid organs like the spleen and liver fracture or lacerate, and they bleed. Hollow organs rupture and dump their contents into a body cavity, and vessels such as the aorta, they tear, and lungs can rupture or they can be punctured. Right before something bad happens, or as something bad is happening, what do some people tend to do? They go and take a big breath, and then bam, they have blunt force trauma, and all that air in their lungs can actually cause lung tissue to rupture. All right, so as you walk up to that motor vehicle collision, MVC, we call it, the rest of the world says it's a car accident. or in 10 codes, it would be a 1050. So as you approach your next 1050, you can count the number of cars and multiply it by 3. That's the 3 collision rule, and that's those right there. Car versus object. This is a very substantial, I don't know, to me that looks kind of like, in a way it looks like a big signpost, kind of like what you'd see holding up those big green signs that go across a freeway, but I'm not sure of that. That was a heck of an impact though, right? We would all agree on that. And how many collisions were there? 3. This one looks like a very significant MOI to me. This vehicle, it looks like to me, this is an old, like a GMC Jimmy or a Chevy Blazer, the small Chevy Blazer, and ran into something much heavier and more stationary than it. You have airbag deployment. So what do we see here? We see crumpled hood. These are called what are they called? Like crumple zones. So that is supposed to help absorb some of the force of that impact. So maybe that disperses some of the energy before that energy reaches that passenger compartment. Oh, what else do we see here? We see deployed airbag. We see a broken seat back. That could leave, that MOI, just of that broken seat pack, could cause spinal trauma. That patient's chest impacting that airbag, even though that supplemental restraint device further dissipates some energy, you still have all this force, even though it's been decreased by 2 different engineering aspects of this vehicle. This person still moves forward. The seatbelt helps decelerate them some more. It also helps keep them in the vehicle so they're not ejected, but they still may impact the steering wheel, but with less force because that airbag is going to disperse some of that. But their head's going to still continue forward, and you can have deceleration injuries, closed head injuries due to deceleration. And I'll show you a coup contra coup injury in a minute, but the brain actually sloshes around inside the cranial vault to an extent. So the brain moves toward the frontal skull and it's compressed. And as that tissue compresses, energy builds there and it kind of springs back. And then it goes back to the back of the cranial vault, and you can get what's called a coup contra coup injury. Besides tearing forces in that tissue within the brain from the brain moving around within the skull, you can also have bleeding of the frontal lobe and the occipital lobe from that deceleration and kind of rebound effect. Look for starred windshields. A head impacting a windshield kind of looks like a little explosion at that point of impact. That's a mechanism of injury that we need to investigate. And this kind of shows you the brain compressing against the inside of the skull from that impact. And then as it rebounds, you can have another impact with the skull in the opposing anatomic area from that compression. This could work laterally also. If this guy's vehicle were to be T-boned and that side impact and he moves to the side, and the side of his head impacts the side of the vehicle, and that compresses the brain to the side, and then it rebounds the other direction. You can have injury on both sides. Okay, this person could have some external bleeding there. It could have a big hematoma on the, and I'll show you pictures of hematomas in another chapter, but in soft tissue injuries. But it could have a great big swollen reddish purple bruised goose egg on the front of his skull here. Then he could also have that coup contra coup type injury. Always look as you size up the scene, and then you size up the vehicle where your patient is. Look to see if airbags are deployed. Are side airbags deployed? Are the front airbags deployed? And make a note of all those things. Where is your patient positioned in the vehicle? Are they the driver, the front seat passenger, rear seat passengers? That's important. Another thing we're going to talk about that goes with a significant MOI and deeming your patient to be a critical patient would be a deceased passenger in the same passenger compartment. Your patient isn't deceased, but everybody else in that vehicle is, then there was a significant MOI there. Seatbelts, airbags, they reduce the second collision, and in a lot of cases prevent that second collision of your patient colliding with the inside of the vehicle. Even with airbags, we still have blunt force trauma that damages internal organs. You can still have penetrating trauma that damages internal organs, and then you can still have extremity injuries. So this one, you have the front end crumpled back to the point that the roof of the car of this little SUV crumpled, and you could expect your patient to have lower extremity injuries from maybe stiffening their legs or just things being crushed back into their legs. With this one, it also buckled the floor pan. That's pretty significant in my mind. And then that seat back being broken over. Good chance of upper extremity fractures, possibly just from gripping the steering wheel and stiffening up right before the impact. It could be that the force of the airbag caused an upper extremity fracture. Somebody who drives with, if you picture a steering wheel here, somebody drives with their arm across the steering wheel like that, you have airbag deployment, they could have blunt force facial trauma from their arm being blown back into their face. So this B pillar, that's what this is. You have A pillar, B pillar, and C pillar in the extrication world. So your A pillar goes beside the windshield. This is the B pillar here. Pretty sure that was cut away by a rescue crew in order to extricate that patient. They cut it there and then push it down, or cut it and get it out of the way. And then, so the doors are gone. Probably use the jaws to pop those doors out of the way, and the cutters to cut these hinges, or at least cut the doors right by the hinges. Those hinges are really tough. Probably easier to cut the other part of the door than that, and use the cutters on the jaws to cut here, maybe here, and then pull that thing down, and then that gives you a big opening to work from. You can see on the opposing side of the vehicle that B pillar is intact there. Okay. The old seatbelt bruise, those hurt. I've had one. I rolled my truck and a couple of times and had a humongous seatbelt bruise. And I would, had I not had a seatbelt on, I probably would have been ejected from that vehicle, and I would not be talking to you now unless you had also met your demise and we were sitting around in heaven having a visit about, I wish I had my seatbelt on. I knew better, but I always, that's one thing I don't skip. I always have my seatbelt on. Okay. But this MOI with the seatbelt, let's say that's an isolated injury on this patient. Maybe they just have this seatbelt stripe here, things that we'd be concerned about. Right there by the left nipple, between the sternum and the left nipple, have this thing called a heart. Could have deceleration forces that injured the heart muscle itself. Could have a pneumothorax. This deceleration forces could have caused a tear, and now when our patient breathes, there's air escaping from the lung and into the thoracic cavity. That goes right across that little medial outcropping of the liver. There's a chance that could have deceleration trauma to the liver, or the stomach could have just a coup contra coup type injury to the organs in the abdomen. They keep moving up on the primary collision occurring, and then the organs keep moving, and then that's the secondary collision, and then they impact the inside of the abdominal cavity. And then there's I'll show you a picture when we do abdominal trauma, and I can't remember off the top of my head the name of the ligament, there's a supporting ligament that helps hold the liver that sits right about here, and it goes vertically on our patient, and it acts like just as if there was a sword inside that abdominal cavity, and you have major deceleration forces to the abdomen, and that ligament can slice right through the liver and cause fatal internal bleeding quickly. Rear end collisions, whiplash type injuries. People in my former profession love those. That's the guys and ladies that advertise personal injury cases on TV. They love these things, right? Rear end collision. I didn't cause this thing. He got a ticket. He slammed into me. What kind of injuries could our patient have? This one is crushed up to the point, if they're backseat passengers, they could have blunt force trauma from everything from the back impacting them from behind. But the head is heavy, and it sits on the, of course, sits at the top of the neck. That was a stupid statement, but the head will rock forward as the bodies propel forward. The head lags behind a little bit, and then it whips forward, and that causes soft tissue tears in the back of the neck, and then it rocks backward, and then that causes soft tissue injuries here on either side of the trachea. Those hurt. I didn't understand whiplash injuries till I got T-boned, and I had a lateral crash type whiplash, and I believe now. I believe, and I apologize to everybody that I thought that can't be that bad, because it is. All right. And if you have a taller vehicle in a T-bone side impact type collision, we just call them T-bones. So from now on, that's probably what I'll call it. In a T-bone, the vehicle with the higher center of gravity will rock away from the side of impact, sometimes even to the point that they overturn. But that you can see where that you have that lateral whiplash type injury as the head moves around. Also, you can have blunt force trauma to the chest, the lateral abdomen, and the pelvis. So you're going to be looking for pelvic fractures, looking for possible pneumothorax, possible, if it's the driver and their impact, have a T-bone on their side, maybe they have maybe their spleen is lacerated and bleeding. So we need to look for those things. We also want to look at intrusion into the passenger compartment. If it's just a bump that damages the skin of the door, that's not a significant MOI. We're not real worried about that probably as far as life threats go. But if that impact causes a 1-foot intrusion or 18-inch intrusion into the passenger compartment, that's a significant MOI. And you can see lateral chest and abdomen injuries, maybe pelvis injuries, lower extremity fractures, could have blunt force trauma to internal organs, and about 25% of all severe aortic injuries come from a T-bone type collision, and that would be or T-bone type crash, and that third collision causes that lateral impact causes shearing forces, and those shearing forces can rip the aorta. And a ripped aorta, if it's a small tear, maybe your patient has signs and symptoms of shock and they can fix them at the hospital. If there's a major aortic shear, aortic tear, those patients are usually dead on the scene. Rollover crashes can happen with any vehicle. In our part of the world especially, you see lots of them from pickup trucks and SUVs. They have a high center of gravity, so turn too fast, skid out of control. It's real easy for those things to roll. And one of the major determining factors in the survivability of a rollover crash is whether or not the people in the passenger compartment were restrained in the vehicle. Occasionally the rollover is at such a high rate of speed, you see things like aortic shears and tears, and you have people who are dead on the scene, or maybe a hangman's fracture. The head snapping around causes a fracture subluxation of C1 and C2 that transects the spinal cord, and those folks are instantly dead also. But if your patient is able to stay in that passenger compartment so that metal is being compressed and dissipating energy rather than them dissipating the energy, they have a much better chance of surviving. Spins or rotational crashes, what I want you to picture there, you have a vehicle traveling toward that camera. You have another one coming at 90 degrees to that. Think of that T-bone that impacts the driver's door, but let's slide it back to that rear quarter panel. So impacts that back quarter of the vehicle and causes that vehicle to spin, to rotate quickly, and you see the same types of injuries with rotational crashes that you see from rollovers. And in rollovers, of course, those guns that I was talking about in that other little scenario, those become flying missiles within the vehicle that can beat the heck out of somebody too. Toolboxes, man, let's see, what else have I seen? Case of beer bottles. Somebody has a case of beer in the back seat of the vehicle, particularly think of a case of beer in bottles, and it's in the 6-pack holders. I've heard about these things. I've never really seen them, but I've heard that they come in these containers that hold 6 of those bottles, and I've heard they have like a division between them to keep them from banging on each other too much, and they all sit nicely in there when it sits in the case at the store, or it sits on the floor at the house, or it sits in the back seat of the car. But when that vehicle starts tumbling and rolling or spinning, those things start flying around and causing blunt force trauma, or they break and cause big lacerations. Sometimes there's only half of you have 24 of those bottles in that case, and half of them aren't there, but there's 12 full ones there, and the missing 12, plus the lack of judgment on the part of the operator of the vehicle, is what led to the trauma to start with. So little cause and effect relationship, right? Car versus pedestrian. These are wicked, man. I have seen some unreal car pedestrians. Picture a little old man who escapes from a nursing home, and in his little hospital gown, I should have spit all over my desk, excuse me. In his little hospital gown, he wanders about a half a mile away from that nursing home onto an interstate highway known as Interstate 40. And he wanders on to the westbound lanes of Interstate 40. And several cars miss the poor little old man who's in his bare feet with his hospital gown on, wandering out onto the interstate highway, until a truck comes along and has nowhere to go without impacting a bunch of cars, and the mirror on that truck strikes the little old man in the head. And from the neck down, he looks like a little old man with a few abrasions. And from the neck up, it looks like mostly he's not there. That was the middle of a weekday afternoon of my life that I responded to that. Nothing for me to do. And then I've had kids run over. Aside from the struck in the head with the mirror of a truck, you have 2 basic types of car pedestrians, and these carry with them different mechanisms of injury. You have the up and over type and the down and under type. So down and under, the vehicle strikes the person, knocks them off of their feet, knocks them down, and then the vehicle runs over them, or doesn't go completely over them. They're tangled up under the vehicle, and they get shredded and mashed and torn, and when the vehicle stops, they're still under there, and you have to figure out how to get them out from under the truck, or out from under the vehicle, to work on them. That would be the down and under. Sometimes they're totally down and under. Sometimes they're partially down and under. Depends on the speed of the impact. And then you have up and over. So you have the impact, lower center of gravity of the vehicle that impacts the patient, taller patient. They fly into the air, or they're just knocked off their feet, and then they bounce over the hood, smash into the windshield. Windshield's all caved in. That can even cause injuries to the occupants of the passenger compartment of the vehicle. So you may have more than one patient there. Very traumatic, psychologically and emotionally if you're the driver of the vehicle, and quite traumatic if you're the person who's run over. And then things to look at, mechanism of injury wise, with the car pedestrian, besides down and under or up and over, is how far the person might be thrown from the impact. Those can be really wicked. I met Corey's father-in-law at a car pedestrian on Amarillo Boulevard in 1981 or 2. He was on a rescue truck and I was on an ambulance, and I remember seeing the back of the coat that said Whitfield, and then from then on, I recognized Paul Whitfield. Now I share an office with him. Somewhere in between here and there, Paul and I were also partners on an ambulance. Quite a bit.
He still tells all the stories.
They don't go away. They become a part of you. I will tell you, they're all loosely based on the truth, not because we want to make up lies, but your stories start to get shuffled together with details of stories you hear other people tell. And then it's not that I mean to lie to you. They just kind of, was that my call or was that his call? Heck, I'm not going to let it get in the way of a good story. So here we go. All right. If you can, try to determine the speed of the vehicle. How do you do that? Ask the driver about how fast were you going when this happened. Whatever the posted speed limit is probably what they're going to tell you. Some would tell you more than that, but most aren't going to tell you at all. They're going to say, I don't know, or I was going 30. Wow, sure. That's a heck of an impact for 30. Must have a really wild car. Okay. Was the patient thrown through the air? How far? What kind of surface did they land on? Did they land on plush green grass in somebody's front yard, or did they land on solid concrete? Did they land on an object? Maybe there were a bunch of car batteries stacked on the sidewalk, and this kid gets hit by a car, goes flying through the air, and then he slams into these car batteries on the sidewalk. So all those things are important. Okay, we talked about up and over versus down and under. The damage to the vehicle. I don't want you to estimate the dollar amount of damage to the vehicle, but was there significant damage to the vehicle? Was there a little bit of meat hanging on the bumper and everything else looked normal? Was there no damage at all? Those are important things to note. That person, the impact takes them up and over and their head crashes into the windshield. That's important. Last thing to go through a bug's mind when he hits a windshield is rear end. That's okay. Let's see. And then if you determine a significant MOI, let's call ALS and get them on the way. Don't hang around on scene. If you get this patient, if you get your spinal immobilization done, you get your patient packaged, and you're ready to transport, ask what their location is and have them intercept you on the way. But don't hang around on the scene waiting forever. They could get in a wreck. They could get stuck in traffic. A train might hold them up. Hopefully they're not going to stop and hold up a train. That was a joke. You can all laugh. That's a pretty good one, but no, I guess not. Greta didn't laugh either. Car versus bicycle, very, very similar to car versus pedestrian, other than the fact a bicycle can go a lot faster than, I had an EMT student one time. He had a class on the main campus before my EMT class on the west campus, and he got a speeding ticket on his bicycle going from main campus to the west campus. I said, Sean, how in the heck? I've gone awfully fast on a bicycle before, and I never got a speeding ticket. And he said, yeah, but you never cussed at the cop when he pulled you over and called him names that resulted in getting a speeding ticket on a bicycle. Okay, so that bicycle could have been, kid could have gotten his first big bike, maybe a road bike with the curved down handlebars and skinny tires, and those suckers can fly. And kid is going maybe 50 miles an hour down a hill, big hill, and a car turns from a road because the car can't see that little bicycle going that fast, and the kid has a head-on collision with the car. The car's going 10 miles an hour. The bike was going 50. Ask bystanders about how fast was the bike moving before the crash. That can be important. All plays into to kinetic energy and mechanism of injury, right? You can have a down and under, you can have an up and over with the bicycle collision with the car, uh, damage to the bike, the position of the bike. Another one that's real important, inspect the helmet for damage. We wouldn't have worn a helmet on a bicycle when I was a kid because there weren't bicycle helmets. I'm old. But inspect those helmets for damage. What part of the helmet is damaged? How many crashes do you think a bicycle helmet is designed to withstand? That's an easy answer. It's somewhere between 0 and 2. It's exactly between 0 and 2, which would be 1. Those things are designed for one impact, and then you get another. They say motorcycle helmets are also, but I wore the same one for 10 or 12 years and hit my head a lot. That's the problem, probably. Absolutely, we're going to have to manage C-spine, well, spinal stabilization in general, not just C-spine, but spinal immobilization, just like we did in lab. Car versus motorcycle, we're getting a little more significant here. What are your protections? You have airbags and you have seat belts and you have these crush zones and all this built in. No, you have a helmet, hopefully, and you have leathers or other abrasion resistant clothing and boots, because none of us have ever seen somebody on a motorcycle without a helmet, with shorts on and tennis shoes and no shirt, with a young lady riding behind them who has on a little no helmet and a thin little summertime top and shorts and flip-flops. We've never seen that, have we? Yeah, we see that way too often. And man, I just want to get out and yell at people when I see that. There's the first half of the word that I want to call them is dumb. And I tried to educate my kids about that when they were growing up. And I told my daughter if I caught her riding on the back of somebody on a motorcycle, if it didn't kill her, I would. So, but I didn't have to kill her. I guess either she didn't do it or I never caught her. Okay. Size up the scene, look at the deformity of the motorcycle, the side of the motorcycle that has the most damage, distance of the motorcycle skid down the road, any stationary objects that the rider of the motorcycle might have impacted after becoming separated from the motorcycle. I can tell you that the cables that we used to call them guy wires, that it's a stabilization wire for like a wooden pole that goes from the top of the wood post. It has an anchor in the ground, and it's a cable, and a guy can fly off a Harley at about 50 miles an hour, and that sucker makes a clean cut right through the femur, and you have a leg and you have a motorcycle rider, and they are not found in the same location, and it bleeds quite a bit. And you get to use a tourniquet. And when back to my not quite as tactful and not quite as laid back self, I picked up the leg and I just stuck it over behind the squad bench in the ambulance, and I'm working on this dude, and he kept yelling at me, "Where's my leg? Where's my leg? What are you going to do with my leg?" And this is stupid. Don't do this. I picked up his leg and I said, "Here is your leg. I'm putting it over here. I don't want to hear anything else about it." And I didn't. But okay. You please be more tactful than I was. That wasn't cool of me. That was not calm and reassuring. It worked. Okay. Again, we can have up and over versus down and under. Head-on crashes, seen those. Those can be quite significant mechanism of injury. It's not the flying through the air part of the head-on crash with the motorcycle and another object or vehicle that causes the problem. It's the impacts. So flying ain't the big deal. With motorcycles striking stationary objects or anybody thrown over the handlebars of a motorcycle, be sure to assess the femurs really, really well. The high-speed impact causing a motorcycle rider to be ejected over the handlebars quite often as they come up and go over the handlebars, their femurs will strike the handlebars and it can cause bilateral femur fractures. And we said that we're gonna, according to your book, we're gonna say each femur in an adult we count as a 1 liter blood loss. So 2 times 1 is 2, even in Borger, Texas, where I grew up. So we're going to count that without anything else as a loss of 2 liters of blood. And in the shock chapter next week, we're going to talk about the fact that a human can compensate for up to 20%, rapidly losing up to, oh man, just lost it, up to 20% of their total circulating blood volume, and without going into hemorrhagic shock. They can compensate for that until such time as it stops bleeding or there's a surgical repair that stops the bleeding. But if we say that the average adult has 6 liters of total circulating blood volume, and 2 liters is 1/3 or 33.33333% of that total blood volume. That's way more than that 20%. So those 2 fractured femurs, your patient may be in decompensated hemorrhagic shock by the time you get to them, and you're fighting an uphill battle to try to keep from losing them. Angular crash, just what it sounds like. There's a concrete wall and the motorcycle, say at a 45-degree angle, doesn't have to be 45, but at an angle, hits that, and that's a different mechanism of an injury than this head-on crash. Ejection, that still sounds hilarious to me, because I think of ejection as somebody thrown out of a rolling pickup truck that's rolling over, but thrown off the motorcycle is what the rest of the world would call it. So ejected from the motorcycle. They're going to travel at whatever speed they were moving until stopped by a stationary object. It could be impacting an object. They could slam into another vehicle. They could just fly off that bike going down the road at 85 miles an hour and slide down the road in their tennis shoes and shorty shorts, sliding down the road. And you can picture those abrasions that make it through the skin, down deep into the muscle, maybe through the muscle and down into the bone. Oh man, those sure got a good tan riding that motorcycle with shorts and tennis shoes, though. Yeah, you can picture some major abrasions there. Control crash, that's just that's a safety technique to try to keep from directly impacting something, is lay a bike down. I have not actually seen it happen, but I ran on a motorcycle cop who had to lay his bike down, and he was able, as he laid it down, to get up on top of the bike and ride it as it slid down the road. That was one of the craziest things I ever saw. I wish I had seen it go down, because I would love this. I bet he was standing up with his hands in the air saying "ta-da" as that thing was sliding down. That's a true professional there. Okay, away from motorcycles to falls. Fall from a height. Significant fall from a height is more than 20 feet for an adult, or more than 1/3 the height of the patient with the pediatric patient. So a baby falling off a bed and landed on their head, depending on the surface they land on, could be a significant fall. Patients who fall from a height and land on their feet could have internal injuries. They could have land on their heels, and that force is transmitted up through their legs and into their lumbar spine, or it's and causes just some soft tissue-ish kind of damage, or it can transmit up through the legs into the spine and have compression forces like compression fractures from that spinal column being compressed. And after the discs, the intervertebral discs can no longer cushion and absorb the force. That force translates into the vertebral body itself and can cause some wicked fractures. Could also have enough compression forces that you have internal deceleration injuries in the pelvis and abdomen. That's why we do a good head to toe physical exam of our trauma patients, looking for those hidden injuries. Factors with the fall: height of the fall, the surface that struck. Was it plush soft grass, or was it an asphalt playground or a concrete driveway? Which part of the body impacted first? Did she fall out of the head, land on her heels, and the forces are transmitted up into the lumbar spine or through the pelvis, maybe fracturing the pelvis up into the lumbar spine? Or did she take a header out of the tree and land on her head on the concrete? So that did. I have a fireman friend who was trying to, in icy weather, trying to use an axe to do vertical ventilation at a house fire, which means chopping a hole in the roof to let the heat out. And the ice had accumulated on the roof, and this particular friend fell from the top of the house, and said on the way down he was just praying that he didn't land on his air pack, and he ended up landing on his belly and knocked the wind out of him, and it hurt, but he got up and dusted himself off and finished fighting the fire. He said sliding down the roof, he had an axe in one hand trying to slam it into the roof to stop on the roof, and it didn't work. All right, penetrating trauma. Oh, that is right beside the left nipple. What is also right beside the left nipple? There's a heart there, right? That could have, depending on the trajectory of the knife, it could have gotten the apex of the heart, could have gotten the left ventricle. Maybe that one looks like it went in at a 90 degree angle, pointing slightly out, but it could have gotten the lung. Just depends on how long the blade is. Try to figure that out if you can. This looks like an old knife. The handle's half gone. Have you had a tetanus shot in the last 10 years? Okay. Can have accidental impalement, like a fall from scaffolding on a construction site, landing on rebar sticking out of the ground, and the rebar stick all the way through the patient. Then question becomes, what internal structures are in the path of that object that penetrated the patient? Knives, rebar and falls, those kinds of things, those are low energy penetrations. And then things like bullets are high velocity, high energy penetrations. If you can, try to determine the path of the projectile that entered your patient. For instance, with a gunshot, you can look at the entrance wound and the exit wound, and you can get an idea of the path. that doesn't mean that that bullet didn't hit bone in there and fragment, so that part of it kind of acted like an internal shotgun blast as those fragments were dispersed within the body cavity. So it takes a surgeon to figure those things out. Let's see. Cavitation. If we were in class, I have a video that demonstrates cavitation. The permanent cavitation is the path that bullet takes the projectile and just where the projectile goes through. And temporary cavitation is the energy wave, the kinetic energy that travels with that bullet through the air. It causes tissue to spread apart. Different tissue has different elasticity than other tissue, but that spreads apart, and that causes additional tearing and additional injury. So by the trajectory of the bullet and looking at the entrance wound and the exit wound, you can't really determine the amount of cavitation, the amount of that temporary cavity. But if you have a big exit wound that gives you an indication of really high velocity punching through that person, you can have an idea that there might be significant cavitation that damaged organs besides just what was in the path of that bullet going through. Okay, the type of weapon, the type of round, whether it's a hollow point or maybe a target round, whether it's a shotgun, all of those are variables in the damage done to the patient. How far the bullet traveled before it got to the person, because drag slows the projectile till eventually it just drops down. Gravity causes it to drop down to the floor or the ground or whatever surface. Let's see. A large caliber bullet can do more damage than a small caliber bullet. A bullet like a 22 long rifle has less powder behind it to propel it through the air and through the patient than, let's say, a 30-06 deer rifle that has lots of powder behind that bullet, and that causes more significant damage as it goes through. Okay, this chart kind of conceptualizes everything we've been talking about and different body parts. If you're into charts, this is pretty good with telling you signs and symptoms and the index of suspicion as far as the type of associated injuries. This isn't a bad thing to look at. We're going to keep on going. Blast injuries. We've learned a lot more about blast injuries in the last 20 years than we knew before because of improvised explosive devices, the IEDs that have been used in primarily Iraq, but also some in Afghanistan. Iraq was where the big time utilization of roadside bombs, of IEDs. You have primary blast injuries. Those are entirely due to the blast. So you have a blast wave. There's a pressure wave of energy that moves and impacts that patient or that person. I guess they might become our patient, or they might be dead and we don't do anything, or they may refuse service. But say that you have that primary blast wave that impacts our patient, and that causes specific injuries. Then you have the secondary blast injuries would be flying debris striking the patient. So you guys may not remember this, but a few years ago, I believe it was the Boston Marathon, had a terrorist attack, and they put a pressure cooker bomb inside of a backpack, and it had nails and other debris in it. And another favorite is ball bearings or BBs in a terrorist type bomb. But that was set off, and then those flying nails, the shrapnel of the pressure cooker itself when it exploded, all of those things impacting a person, that causes secondary blast injuries. And then the force of the explosion propelling the person through the air, that causes tertiary injuries by impact with another object. Then you have quaternary blast injuries, and that's injuries due to burns, crush injuries, toxic inhalation, those sorts of things. All I had to do is turn the page, right? Quaternary injuries: burns from hot gases, inhalation of toxic gases or hot gases, crush injuries from collapsing buildings, those kinds of things are quaternary injuries. We'll talk a lot more about crush injuries later. And patients will have some combination of these four types of injuries. They don't have to have all four. Different organs respond differently to blast injuries. Pressure changes from the primary blast injury that can damage the middle ear. It can just cause the lung tissue to pop, just like popping a paper bag. The GI tract, that's a hollow organ that can cause that to rupture. It can cause the stomach to rupture, depending on what kind of contents are in the stomach. What you will find with patients who have been involved in explosions, they may not be able to hear you talk to them because they may have ruptured tympanic membranes and they may not be able to hear. So you're going to have to find another way to communicate with them. And not being able to hear adds to their stress level and just the overall trauma of the situation. Okay. Pulmonary blast injuries, that would be from just that short exposure to that blast wave. And then you can also see air emboli. Your book, I was taught emboli is the plural of embolism, and I think your book and these PowerPoints uses embolisms, and my mouth cannot say embolisms very well because I was taught something differently years ago in the dark ages. So, but arterial air embolisms it's like an air bubble in an artery. If it's in the retinal artery, that's going to cause vision disturbances. Can have an arterial air embolism in one of the cerebral arteries that produces the same signs and symptoms as an ischemic stroke, because it is a type of an ischemic stroke. Remember, an ischemic stroke is the one that you have a blockage that prevents blood flow. That would be something that an arterial air embolism in the brain could cause, and then other neurologic signs. Solid organs are fairly well protected from that primary blast injury, from that shock wave. The risk to them is impacting stationary objects, or the things which would be the tertiary blast injury, or the secondary blast injuries from missiles flying through the air, other things flying through the air. And then head trauma from causing neurologic injuries from blunt force trauma from the head striking things or things striking the head. The connective tissue, you see this in plane crashes also, really high speed decelerations, traumatic amputations, just an arm or a leg or two arms being blown off. In plane crashes, it's deceleration forces that just dislocate, that's the word I'm looking for, dislocate joints, and then the force tears the connective tissue and causes a limb to be lost. And you also see that with primary blast injuries with a large explosive force. Multi-systems trauma, as I said earlier, that involves more than, and we'll spend more time on these blast injuries. And you feel like I'm leaving something out because earlier I mentioned the quaternary injuries that involve burns, and now I'm not talking about them because we're going to have an entire 2-hour lecture on burn management. So we'll get to that later. Multi-systems trauma involves more than one body system. Head and spine trauma, head, spine, and chest trauma, chest and abdominal trauma, all four extremities, head, chest, and abdomen. We're getting worse. You will see eventually multi-systems trauma, maybe from someone who's ejected from a vehicle, and they have, it seems like, every stinking body system involved. And quite often those patients are dead on the scene before we do anything with them, or they're extremely critical as we transport them, and they may have, their injuries may be so significant that they don't make it. We need to call a trauma alert right away. What is that? Depends on the system you work in and what your protocols are. Maybe they don't call it a trauma alert where you end up working. Maybe they call it a red blanket or various different names, code T or whatever it might be. You're alerting medical control and your receiving facility that you have a patient with significant trauma. So what would you do? You would get on the radio and say, Medic 2 is on the scene of a 3-vehicle collision, calling a trauma alert on patient number 1, who is a 23-year-old male who was ejected in a 1-vehicle rollover, and patient impacted a cinder block wall after being ejected. Patient has multi-systems trauma. Our ETA to your facility will be 10 minutes. Further information while we're during transport, something like that. It depends on the system you work in as to how that works. There are times that you will bypass an emergency department en route to a higher level trauma center. There are some services that don't allow that at all. So I'll talk more about that in a minute. Things to remember: your main priorities, your safety of your crew, and then the safety of your patient. Safety of bystanders is managed by law enforcement. That is not your job. You can yell and get back, get out of the dang road. You're going to get run over. Get back on the sidewalk, but that's not your primary focus. Crowd control is a law enforcement and sometimes maybe a fire department role, but not usually ours, even though we become involved in it sometimes. Don't let that shift your focus from your patient who needs you, though, or shift your focus so that you get hurt. Okay, determine the need for additional personnel. That falls in that primary survey too. What is the MOI? Evaluate the MOI. Identify life threats. Manage those life threats. Find it, fix it. Don't move on till it's fixed, right? If you never get past the ABCs, you never get past the ABCs. Shock management. What is shock management? We're going to learn more about that next week, but we're going to have that shock patient in the supine position with the heater on in the back of the ambulance, with blankets on them, blankets under them, even if they're on a backboard, keeping them warm, spinal immobilization, and rapid transport to an appropriate facility. As I said, trauma is a surgical disease, not a disease you manage medically. Platinum 10, we're shooting for that. Less than 10 minutes on scene. If you never get to a sample history because you're managing life threats, you don't get to a sample history. If possible, get a sample history, and you're going to get that during transport. You're not going to hang around on the scene to get it. And you're going to consider ALS intercept or possibly even air medical. Let's talk air medical for just a minute. If it's going to take an extended time to access your patient, maybe your patient is in a remote wilderness area, maybe air medical is the best way to get to them, or maybe we're going to have an extensive extended extrication time. We could go ahead and call for helicopters so that ALS is there and they have quick means of transportation that isn't going to be hung up by traffic, which is another factor in determining if you're going to call for air medical. Is there tons of traffic between your location, between the scene and the hospital, so that flying them is going to be the fastest way? If the distance to a trauma center is more than 20 or 25 miles, air medical is indicated. Patient needs ALS and there is no ALS level ground ambulance within a reasonable distance or time frame, call for a helicopter. Traffic conditions, en route to the hospital, make it, man, I've been in New York City and watched an ambulance that appeared to be transporting a patient because I only saw a driver up front go in code 3 and get stuck in traffic, and I was walking along with my cane, and 20 minutes later that ambulance is still stuck in gridlock traffic. So a mile, they don't measure things in miles there, they measure them in minutes or hours of transporting. Multiple trauma patients that overwhelm your resources. If you have more than one critical trauma patient, you have more than you can manage. If you have a critical trauma patient and other patients, you can't appropriately manage all of those. So you could call for air medical. You're at least going to need additional ground medical and preferably ALS if that's possible. Some EMS systems require that you transport a patient to the nearest hospital. These are usually political fights. One hospital feels like they always miss out on patients because those stupid medics, they always want to go over there to Mercy Hospital because Mercy has donuts and breakfast burritos 24/7 back in the break room. So they use food to entice those paramedics and EMTs to always transport there. So there's a political fight, and they come up with some sort of agreement that you'll only transport to the nearest hospital. If that's the case and your patient needs a high level of surgical care, then call for a helicopter and they can fly to the appropriate facility. And somebody may get upset, but that's okay. And then mass casualty incidents, we could call a helicopter for that. Patient assessment. We've been doing this all semester, right? This may start, all of what we've done up to now in lab might start coming into focus a little bit. All of these, we're going to spend a whole chapter on each of these. Scene time, get off that scene. Don't jack around there. Get on the road less than 10 minutes. That doesn't mean you have to use 10 minutes. If you can do a good job of your primary survey and you can employ spinal precautions and get your patient packaged, get a baseline set of vitals, get your patient packaged, and get off that scene in 2 minutes and 13 seconds, hot dog, you did something great for your patient, as long as you did a good job of what you know how to do up to that point. Okay, ground units, EMTs and paramedics. Air medical is going to be, usually you're going to have a paramedic and a flight nurse, a flight paramedic and a flight nurse. Why? Because helicopters do a lot more inter-hospital transfers than they do scene flights. So scene flights, usually your flight paramedic's going to take the lead. With scene flights and the critical care, the flight nurse is going to help out the flight medic. Or if it's an inter-hospital transfer, it could be that the flight nurse is going to take the lead and the flight medic is going to help. Flight medic is most always going to be the one managing the advanced airway procedures. And not that the flight nurse doesn't know how to do it, not that the flight nurse isn't proficient. It's just kind of how it falls that's because of our training and experience as medics, we have a lot more training going in advanced airway management. And these are the various levels of trauma centers. Level 1, that is usually, it's a large hospital. It has all of the different services available. What do I mean by that? You have thoracic surgery, you have neurosurgery, you have all these different specialties needed to take care of trauma patients. You have urologists, you have general surgeon, you have trauma surgeons, you have all of these people who are there to manage that patient. Level 2 provides stabilizing care and arranges for transfer if necessary. Transfer would be to a level 1. Northwest here is a level 2. University Medical Center in Lubbock is a level 1. Level 3, they provide assessment, stabilization, resuscitation, emergency care. I think BSAER is a level 3. And level 4 would be like your little regional hospitals, Borger and Pampa. I don't want to leave anybody out. Dumas, Plainview, Perryton, all of those small Canadian, all those small hospitals, those are usually level 4s. They can provide advanced trauma life support care and arrange transfer. So there's going to be a physician there, and they will arrange transfer to, usually it's going to be a level 2 or a level 1 with trauma. All right, let's see. General management, remain calm. If you freak out, you can't help anybody. Organized assessment. That's why we teach you that algorithm. So when the chips are down, you have an organized, systematic way to assess your patient. We're almost out of time. Recognize life threats, treat those life threats. Don't make things worse than you find them. That's extremely important. And always err toward the side of caution and call for ALS backup or contact medical control for guidance. Questions on trauma? No questions on trauma. Either you guys were asleep or I did a bang up job.